Greetings, Graham Warren, working with you on the hip hop case. This one deals with an orthopedic surgical workflow at a fictional hospital, Hipkins Hospital. Two main issues. They're not, their current base case scenario is not satisfactory. They're not happy with the number of surgeries that they're getting per surgeon, and also utilizations are high. And so there's this tension between surgery counts and the profit they're making, provider well-being, as well as patient well-being. So surgeons from the Department of Orthopedic Surgery at Hipkins have been going to conferences and note a sort of rising concern with surgeon burnout, as well as other medical professionals in this environment. And so there's a larger study going on to try and address provider well-being, patient well-being, as well as the profit piece. Sort of looking at two components of the triple bottom line, people and profit. And so they're looking for suggestions around these issues. All right, so let's take a look at the kind of surgeries that they do in this surgical workflow. Knee and hip replacements, so TKAs and THAs. Essentially, we've got appealing to a case by Paul Kanuja, who is at Hipkins Hospital, a director of orthopedic surgery, and we're relying heavily on a 2019 paper that he and his co-authors published. So just to make clear what we're doing, hip replacements, knee replacements, these are used with permission, these photographs. And we've got some information around the age demographics of folks who undergo these surgeries, racial backgrounds, also BMI information. And what's interesting is in Paul Kanuja's paper, of course, with co-authors, he showed that BMI, body mass index, BMI here, is a predictor of the median surgical time shown here. So if you're underweight, supposedly less than a BMI of 18.5, your surgery time is 94 minutes median. If you go to normal weight, 98, 97, and so forth, with a p-value of under 0.05. And then in the same paper, he shows that these ASA, American Society of Anesthesiologists, that their physical status categories do not have a demonstrative or significant impact on the median surgical time. So here is some additional information for gender and racial breakdowns of obesity among adults ages 20 and over, also severe obesity. And so let's move on to sort of a quick look at the surgical workflow. There are four main items. You sort of got a registration process, sedation, surgery, and then from the perspective of the case, cleaning of the OR. Of course, the patient goes on to recovery, maybe transferred to the hospital and discharged. But from the perspective of the case, after surgery, we sort of are interested only in the cleaning of the surgery and then cleaning of the OR and the start of the new surgery. So in the base case, there are two tracks of 2 ORs each, so tracks A and B. Each track is staffed with a surgeon, an anesthesiologist, and these and patients, up to 7 patients, are scheduled each day for knee or hip replacements in each group, in each track, starting at 7:30, and patients are scheduled to arrive every 90 minutes. And there's a 10.5-hour workday, so 630 minutes, which ends at 6 p.m. And anybody who sort of enters the process, arrives for surgery and is unable to complete gets bumped to the next day. So this, is a major source of dissatisfaction of patients to whom this occurs. All right, so I've got an elaboration of that piece, around the median time that Paul and his co-authors published. So we're using those medians as means here, and we also have standard deviations, and then we've also got a breakdown here of the percentage of procedures that are in each of these BMI categories. Okay, so basically what happens, patients come in, they get registered. There could be some paperwork. They get sedated, they get their surgery, and they head off to recovery, discharge, and whatnot. Fraction of them get transferred to the hospital for at least one night. But again, from our perspective, we're just going to look at the cleaning process. So we have some information here for our workflow. We have 2 registrars and 2 VS staff members who work in a pool, each work in a pool to service both tracks. So the 2 registrars register patients in both tracks A and B, whereas the surgeon is dedicated, a surgeon is dedicated to each track, and an anesthesiologist is dedicated to each track in the base case. And then for the EVS pool, there are 2 staff members who clean either, sort of reset the OR back to surgery ready condition. All right, so here's the mean times: patient registration 15 minutes, a small standard deviation. All these distributions are approximately normal. Pre-op prep 20 minutes, standard deviation of 5. So this includes paperwork and anything that's any pre-op prep. Then there's the anesthesia evaluation and consent. So actually, anesthesia is I guess occurring here. We're going to lump these together so that it's prep and anesthesia. And then the procedure here is taken directly from Paul Koenige's paper 2019. So just one point of interest here. We're more than half a decade since the underlying research for Paul's paper, and if you have revised numbers for the means and the standard deviation, make that pivot, just justified appropriately. And then on the room turnover, 40 minutes with a standard deviation 5. Again, this is a 2019 sort of era number. So if you can find automation or anything else that can speed that up, then by all means, justify it with a reference. Could be a provider reference, could be published article, something like that. Then, so we don't worry about the recovery of the discharge in our simulation, but the numbers are present here. Okay, so what does Hipkins want out of us? 2 things. So we've got this base case that's sort of all over the park. They're not happy with the surgery counts. Maybe the utilizations are too high, not a good fit for the provider well-being piece. They're also worried about patient well-being. And so they want to put a penalty on, the total flow times of patients to sort of try and create an incentive to draw down those flow times so that the flow time is sort of a high stress time for the patient, but it's also a high anxiety time for friends and family who are waiting around for the result of the surgery. So by minimizing that flow time, you're definitely providing increasing well-being for the patient and also interested other parties. Okay, so first thing is we want a new a new operating protocol or plan to replace the base case. And you've got some levers you can pull here. We'll get into those in just a moment. They've also noted that there's an optimization tool sort of attached to a simulation model that's been developed for this workflow. And they're interested in finding out if that can sort of just routinely, as conditions change, as maybe technologies improve the workflow, whether they can use that to generate a new replacement operating plan. So it's conceivable that small changes in and the process is going to need sort of like fine tuning, and they're interested in this digital twin as a solid replacement instead of having consultants come in and advise them like we're doing. Can they sort of own this themselves and use the digital twin with some experimentation to push the next designs through. All right, so here are some constraints on the surgical workflow. So there are currently a total of 4 ORs, 2 associated with each track. Now they could be pooled, and beyond that, you can add additional 2 ORs if that's appropriate. They do come with about a $2.3 million capex and associated depreciation. So the essential cost, per year on the capex is at 220,000. There's also sort of utilities and maintenance that runs about 200, so it's about 420K per OR. We'll get there. Right. So on the anesthesiologists, the hospital has decided they want a dedicated anesthesiologist per track, as they have in the base case. And they're happy to hire CRNAs and put those in a pool, or maybe add them to dedicate them to each track at your option. And but the CRNAs cannot outnumber anesthesiologists by more than 2 to 1. And then there's some salary estimates, which again, you can feel free to revise with appropriate justification. 393 for an anesthesiologist, 200 for a CRNA. All the numbers in the case are given in thousands of dollars. Okay. So now there's a burnout red line. That's a default burnout red line has been established by the hospital, but this was sort of, really just a very brief and sort of ill-advised afterthought. They've pegged it at 50%, which is obviously just way too low, and that cannot fly. You'll see that they've got these red lines set at 50%. So first order of business, more or less, is to come in and figure out what those red lines should really look like for the different roles. There are some sort of more mission critical roles here where surgical errors, anesthesiology errors, may have drastically more severe consequences for patients, for lawsuits and so forth. So you're going to need to find new red lines for these different roles, but it's 50% for anesthesiologists and CRNAs in the base case. Let's move on to registrars. You can add registrars. There are currently 2 in their pool in the base case. You could go down to 1, go to 3, and more if you want. Presumably you need at least 1. They get paid 60K. Again, you can revise that number with appropriate justification. They've also got that ridiculous 50% red line. Surgeons and PAs, physicians assistants. So the rule is that you have to have, the hospital rule is that you have to have 1 orthopedic surgeon dedicated per track. Also, you can hire PAs, but you cannot have PAs outnumber surgeons. So PAs could, for example, be used to or deployed to close the wound once the surgery has taken place. Salary estimate 650 for the orthopedic surgeon, PAs 200, again revised with justification, and then the default burnout again is 50%. Fix that. For the EVS staff, these are the folks who sort of return this OR suite back to ready condition. Automation is possible, just justify with appropriate references, and maybe that reduces the time. You'll have to look into that. And then you can add to the EVS staff, you can maybe go down to 1 if that works for you. Salary estimate 60K, again, revised with justification. Burnout, red line 50%, revised with justification. All right, so we talked about a penalty term in the objective for patients. And so what we're doing here is we're valuing patient time at $50 per flow time minute per surgery. That's quite hefty, but basically trying to just shorten their time from time of registration to completion of their surgery. We don't factor the discharge period or the recovery of the discharge time, just from time of arrival to completion of surgery, $50 a minute. Revenue per surgery, we're sort of not distinguishing between hip and knee replacements. It runs $22,000. The surgical tracks and the workflows operate 200 days a year. And then you've got that information around the amortized cost of an OR 220, OpEx for maintenance and utilities and whatnot, another 200, so that's 420. All right, so they want a new operating plan. And then they're also and document all your assumptions, reasoning, and you're going to have to provide simulation evidence to justify your proposed plan. So create scenario analysis and work this up as you would as if that was the only ask. The second ask is, can they use the optimization tool associated with the model to sort of like take that combined simulation and optimization package as a digital twin for rough cut staffing planning going forward. All right, so they want data-driven recommendations and careful motivations and tell the story. Your deliverable is a video presentation, ideally uploaded to YouTube, and so I suggest avoiding screenshots of the AnyLogic model. Create a table of the results that you want to accumulate. Maybe one screenshot just to sort of introduce the model, maybe a screenshot of your final recommendation. But in general, that AnyLogic model is frantically busy and complex for a hospital administrator to encounter for the first time in a presentation. All right, so there's a hard limit of 10 minutes. Take a look at the case response guidelines again. Your video needs a bluff, and you need to close it out with a strong conclusion. Again, the conclusion and the bluff pretty close mates, and they sandwich your analysis. Got your rubric, and you've got some references, some of which are recent. The original Kanuja paper here from 2019 is this one, and you can find that quickly on Scholar. So here is your base case in the AnyLogic model, and you can see it's just a ton of stuff in there. So we'll explore the modeling in the next clip, and in the third clip, we'll document the base case and some thoughts about that, and then from there we're going to look at process improvements, perhaps in a couple of videos, a couple clips, and then the final clip will deal with the optimization tool and the choices that have been made in there.